So hi everyone, welcome to our webinar today with Dr. Charles Drake from Columbia in New York. Our subject today will be prostate cancer and immunotherapy, and we're doing this in a time of what we call crisis, which is the coronavirus pandemic. So we're very happy to have him. Joel Nowak will be our moderator. He's the CEO of Cancer ABCs and the co-founder with his wife, Wendy Leibowitz. My name is Jan Manwright. I'm the Executive Vice President of Cancer ABCs. Joel and I both have extensive personal stories with cancer and to a point of a lot of stress and crisis that we overcame and desired to pay forward and turn into something positive. So that's the reason we do what we do. I want to tell you how we do our patient education advocacy and how we're doing this webinar. First off, I want to make it clear that we cannot give medical advice, and neither Joel nor I or our medical professionals, but also Dr. Drake. Physicians will not give medical advice from a podium or a webinar. That's something they do in the clinic. However, our goal here is to help you, and there's so many ways that we're going to do that today. One is hopefully to help you understand your own situation or your own cancer better. Another simple way is to help you understand both risks and benefits of treatment. There's two parts to every treatment decision. It is risk and benefit. And that should lead you to a place where you can ask better questions of your doctors and nurses. And a simple phrase I'd love for you to remember is that better questions will get you better answers. So focus on developing better questions. All of this, we hope, will lead you to a place of engaging in shared decision-making with your physicians. Shared decision-making means you share the decision with the doctor, and the doctor shares the decision with you. I've got to mute.
I'm happy to deal with it, but this is the second we had the same problem earlier in the week.
And we're good. Okay. I feel like the Geico commercial.
The mute.
Yeah. So that's what we're going to do today, and I'm really looking forward to it. I want to thank and give credit to our sponsors. We've got Janssen Oncology, who is the maker of Zytiga and Erleada. You can find information on those drugs at zytiga.com or erleada.com. Dendrian is the maker of the only immunotherapy that is FDA approved for metastatic prostate cancer, with some other caveats to that, but the name of that immunotherapy is Provenge. You can find information at provenge.com. Bayer is the manufacturer of Xofigo and Nubeqa, and you can find that information at Xofigo. I believe it's xofigo-us.com and nubeqa.com. Astellas and Pfizer are the makers of Xtandi, and you can find that information at xtandi.com. You can also find all of this information at our website, which is cancerabcs.org. So I'm going to turn it over to Joel Nowak and Dr. Drake, and they can take it from here. I'm going to go into full screen mode here. So.
Great. Thank you so much, Jan. I just want to say for everybody who's on the call that we are really, really fortunate to have Dr. Charles Drake with us today. Dr. Drake is, without a doubt, the foremost expert on immunologic therapy, immunology in prostate cancer, and it's really, really difficult in normal times to get him to really spend time, and especially to do it now during the COVID crisis. So we are really lucky. He's an amazing person, besides being an extraordinary doctor and an extraordinary researcher. Dr. Drake spent a lot of time at Johns Hopkins, and those of us living in New York are blessed now to have him up at Columbia University, where he is a full professor of medicine and full professor of urology, and the director of GU oncology for the entire hospital. He is an amazing guy, and I'm just really looking forward to his presentation, and I love whenever we have an opportunity to listen to him and to ask him questions. As we go along, Dr. Drake has agreed to take questions. So if you have any questions, please go ahead and fill them in on the chat box. And it's possible that we may even be able to get some people live. But actually, welcome, Dr. Drake, and thank you from the bottom of my heart for coming on and joining us today.
Joel, thank you for that very kind introduction. You're making me blush. It's actually always a privilege to talk to patients with prostate cancer. This is who I am, and I appreciate the kind introduction. Janet, could we have the next slide, please?
Sorry, hang on just a second.
These are my disclosures. Actually, these are folks that I advise on how to develop drugs for prostate cancer and for immunotherapy. Unlike many talks like this, I'm going to do something that we're not supposed to do, but I don't care. I'm going to use the names of the drugs as trade names because if I found that if you say abiraterone acetate, the patients, they often don't get it, but if you say Zytiga, it's well understood. And so I will use those trade names, which we're generally not supposed to do, but I think it'll make it clearer. So in today's talk, I think one of the things that Joel asked me to talk about is a little bit of how prostate cancer and its treatment sits in the time of COVID. And I thought about just talking about COVID, but as I started doing that, I realized that that wouldn't really make sense. So what I'm going to do is go through a talk where we talk briefly about the natural history of prostate cancer. Then we talk about several of the treatment modalities. And at that time, we'll talk about how they would interact with the propensity to be infected with COVID-19, actually. So first, we'll talk about hormonal therapy. Then we'll talk about immunotherapy, treatment with sipuleucel-T or with chemotherapy. And finally, I'll talk to you about immune checkpoint blockade using drugs like Keytruda and talk about the idea of whether those drugs make a patient with prostate cancer more or less susceptible to infection with COVID-19. So could we have the next slide, please? So this is a figure from a review paper that we wrote that shows how prostate cancer evolves over time in most patients. And many patients, their journey won't go through the whole course, but most patients in the United States, at least, are diagnosed with local disease. And for local disease, they get treated with local therapy, usually with curative intent. And by that local therapy, we mean radiation or surgery. And fortunately, many patients are in fact cured by radiation or surgery, but of course not everyone. Those patients generally manifest as a rising PSA, and at some point, either before or after they develop metastatic disease, they're treated with androgen deprivation therapy. There's a lot of names for this. You can say hormonal therapy, ADT, et cetera. Chemical castration is a very unpopular term. But those are the early treatments. And the reason that's important is very simple. They work, actually. They work brilliantly. The response rates are huge. They're among the highest in oncology. I mean, hormonal therapy for prostate cancer works 95 to 98% of the time. If we had therapies like that in other cancers, we'd be very happy. We have nothing like that in bladder cancer or kidney cancer, actually. Usually that works for some period of time, sometimes forever. If the cancer progresses after that, patients are often treated with second generation newer hormonal therapies or chemotherapy. Have the next button, next press, please, Jan. So first we'll talk about a disease state called biochemical recurrence. And what this means is that patients have had local therapy and their PSA is rising. But if you do regular CT scans and bone scans, you don't find anything. So the only evidence that the cancer is coming back is in fact biochemical evidence. That's called biochemically recurrent prostate cancer. Now you know as well as I that if you've had your prostate gland out, that PSA is coming probably from some cancer cells. And the question is, can you find those cells? And if you find them, can you do anything about it? And I would just like to introduce or briefly remark on a novel imaging technology, which is very likely to be FDA approved either the end of this year or early next year. So you have the next slide, please. So that's based on a target called prostate-specific membrane antigen. And some of you may have heard of imaging using choline or acetate or things like that. And they all have their places, even oxymin, but prostate-specific membrane antigen is, just like the name says, more specific. This molecule is expressed almost only on prostate cancer cells, and there have been multiple attempts to image this. It's also strangely in the salivary glands, which is one of the signs that your scan is actually working, is you should light up the salivary glands. So we have the next slide, please, Jen. So this is an example of a patient whose PSA was rising after surgery. The PSA was 7.8, but when they got a bone scan or a CT scan, there was nothing but air. We know, again, if the PSA is rising, there probably are cancer cells somewhere. And this PSMA scan, by the bright red arrows you can see, showed cancer in the lymph nodes that drain where the prostate gland used to be, actually. This patient, in fact, has local recurrence in the lymph nodes. Now, in some of these patients, we get lucky. We find just one red dot, just one site of recurrence. And when we do that, we generally treat them with local treatment, usually radiation therapy, although some have advocated for even for surgery in this kind of a setting. When you do that, that's usually not curative, but that usually delays progression for a very long time, sometimes for years. So these scans will become increasingly used, mostly in the setting of a rising PSA after surgery or radiation, and then it'll drive the next therapy. If there are clear local lesions, they'll probably be treated locally. And if there's more widespread disease, like in this patient, they'll be treated with systemic disease. And you can see after they were treated with hormonal therapy plus chemotherapy, it worked. Basically, the lesions went away and the PSA became undetectable. So I think this is a reasonable time. I think if Joel agrees. Do you have any questions on the idea of PSMA imaging at this point? Joel,
if anyone has a question, in the meantime, while we're waiting a second, Dr. Drake, could you talk a little bit about the actual sensitivity of the PSMA scan? What PSA would one expect to start seeing results that are usable?
Great question, actually. So it's definitely more sensitive than a bone scan or a CT scan, which usually become valuable in the range of 20 to 30. And the studies that have been published from UCLA and UCSF, these scans are generally useful at a PSA around 1. Now, in some patients with a PSA as low as 0.5, you can detect lesions, but really they become more reliable at a PSA of 1 or so. And actually, the higher the PSA, the more likely you are to find something. Although I have to say it's a little bit variable. We have an ongoing trial at Columbia, and we've had patients with PSAs as low as 0.5, where we find a beautiful clear lesion that we can treat. And we've also had the opposite happen, right? We'd have patients with a PSA as high as 5 or 7, in which the scan doesn't really show anything clear. So that's the sensitivity. And some people also think of it as the detection rate, right? So the higher the PSA, the better the detection rate. What's also important, though, is the specificity, right? So when you see a lesion on the PSMA scan, is that in fact prostate cancer? Results are still coming in from studies on that, but there was a small study out of Baltimore, out of Hopkins, where it used to be, that showed that the specificity, that is, if you see a dot like one of the red dots on the left, how often is that prostate cancer? And the answer was most of the time, like 90 to 95% of the time. So we don't really know the sensitivity yet, but we have a very good feeling that the specificity is very, very good.
So if you mentioned that in some cases, somebody can have a PSA as high as a 5.0, and yet the PSMA scan will be negative. And if they've had surgery or radiation and they're off their nadir, or where their PSA has leveled out post radiation, what would their options be? What should they be asking their doctors to do? Because obviously there's something there.
That's a great question, and we'll get to a little bit that in a couple of slides down. But usually for patients who have rapidly rising PSA after surgery or radiation and no evidence of treatable local disease, most of those patients will think about hormonal therapy. But the decision of when to initiate hormonal therapy is a very challenging one. There's not really any clear standard. In my clinical practice, what we look at is not only the number, not only the value of the PSA, but also how quickly it's going up. It turns out that patients who have slowly rising PSAs really don't need to be treated with hormonal therapy right away. They can wait for quite a significant amount of time. However, if the PSA is going up fast, right, if it doubles every 3 to 6 months or so, those are patients that probably should be treated.
So do you have like a cutoff of the doubling time or how quickly it's rising that you usually use when you make a decision whether or not to continue or start treatment or not?
Yeah, it's interesting. So most of the studies that looked at your risk of getting metastatic or progressive prostate cancer came up with a number of about 9 months or 12 months. So when the PSA doubling time is less than 9 months, 12 months, that's when we're pretty much leaning towards using the hormonal therapy without seeing metastatic disease.
Great. So I don't see any more questions coming up, so maybe I'll let you move on.
This is Jan.
That'd
I
be
have
great,
a question. No, I have a question. The PSMA scan is a PET scan, PET, correct?
Correct.
Yeah. Some people don't always know that a PET scan can be different. There's different PET scans, and it's the actual injection itself that names the PET scan or makes it different. So this is different than an FDG glucose, or there's an Axemin PET scan. This is a different type of PET PET scan.
Absolutely, actually. And to add to that, most of these scans are not done just as a PET scan. They also include a CT scan,
right?
Because the CT scan that's done at the same time helps you precisely localize where a lesion might be, actually.
And the second question I think people will have is, where can I get this? And I think it's important to say it's not FDA or cleared or approved yet, although I understand there's two PSMA PETs right now, correct? One is with UCLA and UCSF, and they've submitted for approval, but they may not have had it yet. Is that correct? And then the second one is this one.
So honestly, Jan, probably we have a trial at Columbia. We'll do imaging on 300 patients over the next couple of months, and there's several studies where you can get this kind of scan now.
Okay.
There are two flavors. To be honest with you, the flavor doesn't matter. The imaging has similar sensitivity and specificity.
And it looks like they can both be studied and approved for the setting of recurrence, although one might be approved for the setting of newly diagnosed. Is that correct?
Time will tell.
Okay, got it.
But
right now there's none available unless you find a clinical trial, and we don't think there's any in Florida, but probably New York. Is this one of the trials then that is still ongoing, even with coronavirus?
No, all our clinical trials, interventional or non-interventional, were unfortunately
including
closed.
PSMA PET scans.
Yes.
Okay. So for now,
actually, I want to jump in because Jan, we have a question from somebody from the group. It's if a patient is metastatic but hormone sensitive, in other words, they're still responding to ADT or hormone therapy, how often would that patient need to be scanned?
It's a question for the ages, and also the phrase there, "need to be," is a good question, actually. So when patients have metastatic disease and are treated with hormonal therapy, most of the clinical trials that treated those patients with hormonal therapy image them either every 3 or 6 months. So that's one standard of care. You just get an imaging every 3 or 6 months. But realistically, if the hormonal therapy is working and you document that by a falling PSA and have a scan showing the cancer is either stable or shrinking, getting very frequent scans actually doesn't really help your management all that much, actually. So the answer is, in general, on trials, they've been imaged every 3 months on the average. But really, once the hormonal therapy is working, you probably don't need to do it that often, actually.
Great. Thank you for the answer. So go ahead. Let's move on.
Okay. And so this is, again, the idea of initiation of androgen deprivation therapy. In the next couple slides, we'll clarify for folks exactly how that works. And then we'll talk about why that might be a good thing in the setting of COVID. So next slide, please. So for prostate cancer cells, testosterone is fuel. It's like the gas for your car, actually. And so when you cut off the supply of testosterone, the car stops running. For prostate cancer cells, they actually die. They undergo programmed cell death. Most of them do. Not all of them do. We wish all of them would, because if they all die, then androgen deprivation therapy would be curative, actually. But the way I like to think of it is hormonal therapy, androgen deprivation therapy cuts off the fuel to the car. So next slide is good. And so the way this axis works is it starts in the brain, where there's a chemical called LHRH that goes through the blood to the testicles, and it tells the testicles to produce testosterone. So that's how you normally control your levels of testosterone. LHRH from the brain, LH talks to the testosterone, talks to the testicles, they make testosterone. The way these drugs work actually is they tell the brain to stop making LH. So next click, please. So there are many drugs, and you know them by name: Lupron, Zoladex, Eligard, Trelstar, Firmagon. There's multiple hormonal therapies, androgen deprivation drugs, but they all do the same thing. They take your testosterone, which is normally over 300, sometimes as high as 600 or 800, and they make it go down low, less than 50. So when the testosterone is less than 50, prostate cancer cells mostly die, and that's androgen deprivation therapy. And that's one way to do it, actually. Next slide, please. There's another way to do it, actually, and that's to stop the testosterone from hitting its target, from stop hitting the target in tissues, which is called androgen receptor. So normally the testosterone hits the androgen receptor, and that fuels prostate cancer growth. Next click, please. But what androgen receptor blockers do is they block up the place where testosterone would normally bind, so that even if you have testosterone sitting around, it doesn't hit its target. So next click, please. So that is the testosterone. These little balls of testosterone no longer hit their target because the target's blocked by these androgen receptor blockers. And then what happens is, next click, please, is that there's almost no growth. These blockers all have the same last name so that you can remember them. They end with amide. So there's bicalutamide, flutamide, nilutamide. These are the first generation of androgen receptor blockers. And if you think about it, sometimes it's good to both block and cut down the number of blue balls by decreasing testosterone. And that's a combination hormonal therapy, often given with things like Lupron plus Casodex. So that's how hormonal therapy or androgen deprivation therapy works. Next slide, please. You know, if it was that simple, we would be very happy. Unfortunately, androgen deprivation therapy, as probably many people on this conference can ascertain to, has many side effects. So one, it causes weight gain. It can cause mood changes and loss of energy. It can cause biochemical changes, including increased cholesterol, increased blood sugar, can steal calcium from the bones, and it could also cause immunological changes. In my practice, and recent and actually older clinical trials really show very clearly that the key to many of these side effects is, in fact, regular exercise. Regular exercise can combat the weight gain, can combat the mood changes, and surprisingly, it even seems to combat to some degree the loss of energy, which is a little bit counterintuitive, right? You think like, oh man, I don't really feel like exercising, but if I exercise, I'll have more energy. Unfortunately, that's what studies show. It does work that way. Many people with prostate cancer are on hormonal therapy. And in this time of COVID crisis, you might say to yourself, does that make me more susceptible to the virus or less? And the answer is actually pretty clear. It probably makes you less susceptible to the virus. That's because one of the ways that the virus gets into lung cells is through a molecule called TMPRSS or TMPRSS. When you go on hormonal therapy, the level of that protein goes down, so it's not as easy for the viral particles to get into your lung cells. And so if you're on hormonal therapy, you're probably not at greater risk of getting the virus. If at anything, you're probably at lesser risk. And to prove it, actually, there's even a clinical trial that's initiating hormonal therapy, believe it or not, in patients with the virus to try to make the virus not get into the lung cells anymore, actually. So that's what we think about hormonal therapy and COVID virus. I'll take a few seconds to allow folks to sort of digest that and any questions about those concepts.
Was there a question in the audience? No. So, Dr. Drake, does it matter what flavor of hormonal therapy one uses as far as controlling the TMPRSS gene?
Probably not, although there's ongoing studies in laboratories, right? Taking prostate cancer cells and sprinkling these drugs on them and seeing if that makes the virus enter less. So it could turn out that there's one flavor that's better than others, but to be honest with you, it's probably not going to be that way. It's probably going to be like if you're castrate, if you have low levels of testosterone, it's probably harder for the virus to get into your lung cells. And how you got there probably doesn't matter. actually.
And what about if you use, by the way, I love your illusion about the gas in the car. And when you were talking about the Casodex and the blockers, I was thinking you just don't take your gas cap off of the car and you try to jam the gas thing into it and it doesn't go in. So anyway, that's your new slide for you.
Good.
Now you spoke about immunologic changes for COVID. What about generally? Does that also seem to be a similar effect if one's on hormone therapy?
Yeah, it turns out that autoimmune diseases are more common in people who have lower testosterone. Those people are called women, right? So autoimmune diseases, the body being more immunologically active, happens more in women than men, and that's probably sort of a manifestation of what happens with hormonal therapy.
So there is a question: how long does the Eligard effects last in the system?
Yeah, it's a wonderful question, actually. And I have to tell you that many doctors answer this question wrong. Okay. So when patients are treated with those drugs, those ADT drugs, those hormonal drugs, Lupron, Eligard, Trelstar, those drugs, what happens is it turns off your brain's production of LH. After you stop those drugs, they have to wash out of your system, and it takes your brain a while to recover. If you're 80 years old and you start hormonal therapy, there's a 10% chance that your brain will never, ever, ever recover the ability to make LH. And so it turns out that 80-year-olds, 10% of them are permanently castrated with one dose of Lupron or Eligard, one dose. In general, these drugs take a while to wash out of the body. The median time, we did a trial of this with the vaccine Provenge. The median time for Eligard to wash out is pretty long. It's in the range of a year. So if you stop your Eligard today, right, got your last shot today, you probably wouldn't have a normal testosterone for around a year or so. It's important to remember with any kind of disease, including prostate cancer, everybody's different. And so I've had patients who have had their testosterone bounce back really quickly, 3 to 6 months, and patients who, as I mentioned, have never bounced back. But the average is around a year or so. It's a good number.
And is the ability to bounce back, because you mentioned an 80-year-old person, can we assume that the older a person is, the less likely or the longer it would take to bounce back?
That's a very general truism. So patients who are, it goes up with age, the ability to bounce back. But I got to tell you, I got a couple 70, 80-year-old guys in my clinic who, second the Eligard stops, 3 months later, 6 months later, the testosterone is flying, 600, 800 actually. So it just points to the striking variability in how fast your testosterone could come back.
Great, thank you. Any other questions before we move on? I don't see any. So Dr. Drake, would you mind?
Yeah, please. Okay, so next slide, please, Jeff. So it turns out that initial hormonal therapy, usually with one of those drugs, one of those shots, Lupron, Eligard, Trelstar, usually lasts for some period of time. How long it lasts is very, very patient dependent and also not very predictable. In one of the Hopkins series, it seemed to last for around 5 years. More recent studies suggest in some patients it might be a little shorter, 3 years, but there are patients who are treated with hormonal therapy and it lasts forever. What I always tell patients, though, is if you live long enough, and I always hope that they do, eventually the prostate cancer cells are going to figure out a way to grow in the absence of testosterone, and we call that castration resistance, actually. If you develop castration resistance, that is, you're on Lupron and the PSA starts to go up, that used to be something that was very worrisome, and the major treatment we had was chemotherapy, but now we have much better treatments, actually. So we have the next slide, please. So these are the treatments for what happens if hormonal therapy or ADT fails. One treatment that we'll talk about briefly is immunotherapy with sipuleucel-T, also known as Provenge. There are new versions of hormonal therapy, better, stronger, faster, named Zytiga, Xtandi, or Lida. Other ones actually that will darolutamide, which we'll talk about. There's chemotherapy, which we'll mention briefly. and there's also bone-targeted agents. So it used to be that if hormonal therapy stopped working, things didn't look so good. That's not really true at all anymore. There are many, many treatment options. So next slide, please. The treatment option that patients should think of first, if they're ever going to think about, is to use Provenge. Provenge, or sipuleucel-T, is a vaccine. It's a vaccine made from your own blood cells. In this process, patients undergo leukapheresis. Their white blood cells are shipped to Atlanta on a plane. When they get there, they're turned into a vaccine by cooking them, by culturing them in a dish with a gene for prostatic acid phosphatase. After this, the cells are shipped back and they're infused into the patient live. This is the first round. It turns out this has to happen 3 times for the optimal effect. One is called a prime, one is called a boost, and one is just an extra dose. This has been shown to help prostate cancer patients live significantly longer. But I have to tell you what's happening now with the other medicines available. A lot of doctors jump past this, and this really shouldn't be jumped past. If a patient has an adequate immune system and not a lot of tumor burden, using this vaccine early on is probably something that should be thought about. This is really a fairly quick process. It takes only about 6 or 8 weeks, and in no way precludes other treatments in the future, actually.
Dr. Drake, I want you to come back because you used the word vaccine. Now, I get a vaccine for the flu, I get a vaccine for polio, but this is not really a vaccine in that way, is it?
So, great question, Joel. So the vaccines that you get for flu or polio work very differently than this. So those vaccines are designed to make your body make chemicals or proteins called antibodies. Antibodies neutralize things from getting into your cells. So, for example, antibodies to COVID proteins stop COVID from getting into your lung cancer cells. Antibodies to polio stops polio from infecting your cells. The immune system fights cancer very differently. It fights cancer with cells. We'll talk about those a little bit later, but those are called immune cells or T cells. So this is not a vaccine designed to make antibodies. It's a vaccine designed to raise T cells, immune cells against the vaccine. And honestly, all those vaccines you just mentioned, brilliantly I might add, those are given when you don't have polio, when you don't have the flu. It's a lot harder for the immune system to build up a response to something that's already in you, right? And so that's why it's a different kind of vaccine, and it takes just a little bit harder for it to work.
So are there racial differences with benefits for Provenge that you're aware of?
Yeah, surprisingly, actually, Provenge, there's some data that Provenge seems to work better in African-American patients. This is fascinating. It suggests that their tumors have a different immunological, or the patients have a different immunological context. My lab is studying this now, and we found in the peripheral blood of patients treated with Provenge very big differences in the way that African-American patients respond than Caucasian. It looks like Caucasian patients certainly benefit, but it looks like there's a better benefit or a more prolonged or pronounced benefit in African-American patients.
But Caucasian patients do get a benefit from it.
Oh, of course, actually.
Yeah. So I just want to know, there is a question out, which I don't want you to answer yet, but I just want to put it out on the thing because maybe you can answer it as you go through your slides. The question is, how does SIP-T or Provenge differ from CAR T therapy? And since you haven't gotten the CAR T therapy, let's just hold that in abeyance. But if, as you do your presentation, maybe you can reflect back on that.
Absolutely. We have a slide where we show some pictures of T cells, so we'll talk about it then. That's great. Good. Next slide, please. So another treatment for cancer that stops responding to initial hormonal therapy besides the vaccine is chemotherapy. Chemotherapy is usually starts out with docetaxel, known as Taxotere, and this is regular chemotherapy. It can cause fatigue, hair loss, tearing, nail changes, but in the era of COVID, it's important to know that this kind of therapy decreases your immune system. Basically, the chemotherapy kills the white blood cells that are designed to stop, to kill COVID-infected cells. Those are called T cells. So basically, chemotherapy most certainly would increase your chances of getting infected with the virus or having the viral infection being more severe. In our cancer center, we have patients who are on chemotherapy, who need chemotherapy, and we're still giving it because although real, the risk of COVID infection and subsequent pathology for these patients is less than their risk from their cancers. But it should be noted that chemotherapy is not the immune system's friend, and it's generally something that would be expected to make the rate of COVID infections or the severity of COVID infections be worse, actually. Any questions on this particular part?
Any questions out there specific to this? I don't see any, so let's go ahead.
Perfect. So in addition to those therapies, what really most patients get who progress after initial hormonal therapy are these SuperBlockers. There's two versions of next generation hormonal therapy. One is the SuperBlockers. These are drugs that also end with amide, Xtandi or Leta, darolutamide, which is Nubeqa. These drugs are brilliant. These block very beautifully to the androgen receptor. Next slide, please, Jan. And they really block the ability of testosterone to signal to prostate cancer cells. And by blocking that, you can treat patients who have progressed on either Lupron or other drugs like that. Next slide, please. And actually on this one, I wrote this on purpose. I wrote no growth, not just slowing down growth. These are really powerful drugs. And in many patients, they really fully arrest the growth of prostate tumor cells, actually. Another way to do this actually is when you get Lupron or other drugs like that, Trelstar, Eligard, those kind of drugs, those drugs lower the testosterone, but they don't make it zero. Patients who are on Lupron or Eligard usually have a testosterone in the range of 5 to as high as even 40 or so. It turns out that that little bit of testosterone matters, actually. And so if you could get the testosterone even lower, some patients might respond. And that's what the drug called Zytiga does. So Zytiga is a super inhibitor. It really knocks down the ability of the body to make testosterone. Testosterone levels go to effectively zero. New assays had to be developed to measure testosterone in these patients. And so those are how those new drugs work. Next slide, please. So this is an important concept, actually. So if patients are treated with hormonal therapy and it stops working, a question often comes up with the urologist or with the medical oncologist, and patients will be encouraged to get genetic testing. And you know, for some cancers, why you should do this is very clear. For prostate cancer, it's not always clear, but I'm going to tell you why you might want genetic testing of your tumor. One answer is if the prostate cancer has a lot of mutations, that's called MSI, then immunotherapy using the new drugs like Keytruda has a reasonably good chance of working. So if the prostate cancer is highly mutated, you want to know it. You really just do, because then you would go on FDA approved, by the way, pembrolizumab, and that would have a good chance of working. It also turns out that there's a bunch of mutations that affect the ability of a cancer cell to fix its DNA when it's broken. Those are called DNA repair proteins. And if your cancer has a mutation in one of those, then there's another class of drugs that might work. And I'll show you that in a second, actually. Those mutations are ones that you might have heard of from your friend Angelina Jolie. Those are mutations like BRCA1, BRCA2, and APC. So if your cancer has either a mutation in APC or BRCA1 or BRCA2, or a lot of mutations, honestly, that's something you want to know about. So if you have metastatic castrate-resistant prostate cancer, getting a biopsy is a very reasonable approach. Next slide, please, Dan. It turns out that this is fairly common. These mutations in these DNA repair genes, about 10% of prostate cancer patients have these at baseline, and another 10% get them in the tumor. So all in all, about 20%, about 1 in 5 prostate cancer patients has a trouble fixing broken DNA. And when they have that, that means that these drugs that further break the DNA are likely to work, actually. The name of those drugs are olaparib or Lynparza, which has recently been FDA approved, if you got the mutation. If you don't have the mutation, it's not going to work. And so it's actually very important example of molecularly targeted therapy, probably the first time for prostate cancer, actually. So that's the idea for PARP inhibitors. Next slide, please. This slide shows how it works. Basically, this is broken DNA, and there's more breaks if you can't fix them. So if you have a BRCA mutation or an APC mutation, your DNA is breaking. More if you stick that PARP inhibitor in there, you really can't fix it, and that leads to prostate cancer cells dying. And it kind of works, actually. The rate of cancer cells, prostate cancer shrinking on these drugs is good. It's at least 50%, actually, which is pretty good for later stage disease. It turns out that, again, about 20%, about 1 in 5 patients with advanced disease have these mutations, and that's one of the major reasons you want to get sequencing. Next slide, please. The other reason is this, actually. So it turns out in the world of cancers, some cancer cells are full of immune cells. It's a beautiful thing. This happens in melanoma quite frequently. Most melanomas, most skin cancers have this. It happens in kidney cancer. Most kidney cancers are on the right. They're full of immune cells. That's awesome. It turns out that there are some tumors where this happens once in a while, like lung cancer. Lung cancer, about a quarter of cancers are kind of hot, full of immune cells. Prostate cancers aren't like that. Prostate cancers are cold. They don't have a lot of immune cells. The reason they don't have a lot of immune cells is probably because they don't have all that many mutations. So the immune cells are attracted to differences in the tumor versus normal cells. And prostate cancer cell just doesn't have that many mutations, not that different. Most patients, not that many immune cells, actually. But if patients have a lot of immune cells, next slide, please, then anti-PD-1 Keytruda can work. So these are patients who have hot tumors. These are patients who have microsatellite instability. This is determined using sequencing, like I talked about. These are patients from Memorial Sloan Kettering by my friend Wasim Abida. He went through their whole database, and he found out that 1 out of every 50, which is not a lot, but it's more than 0, patients have this microsatellite instability. Lots of mutations, lots of mutations. That's good. Anti-PD-1 drugs, Keytruda, work sometimes for a very, very long time, years, in fact, actually. And so you also want to know if your tumor has microsatellite instability, lots of mutations. In my clinic, I have a small number of patients, about 3 or 4, who have these mutations. And I have to tell you, in some of them, treating them with Keytruda has been really nearly miraculous. These are patients who progressed after chemotherapy, looked very badly, and we sequenced their tumor. They had microsatellite instability, and it tends to work, actually. So this is another reason why you want to know that you have a lot of mutations. So next slide, please. And the next slide, I'm going to tell you exactly how Keytruda works so that you can understand how you might think about ways to make it work better. On your right, you see a prostate cancer cells, and the yellow blob represents a mutated protein. Mutated proteins are recognized by the immune system. Joel, these are the cells we were talking about before. Sipuleucel-T is supposed to build these killer T cells. These cells are awesome. They can kill any cell in the body. They can cross into the brain. They can go into the bone. When they get into the tissue, they're like loose cannons, though. And so what the body did was it built a brake. It built something to turn them off, and that's called PD-1. So whenever a T cell, a killer T cell, gets into a tissue or into a tumor, most of the time it builds a brake. It builds the PD-1 molecule, which would turn off the tumor. But it doesn't go off by itself. What happens, next slide, please, is the immune cell first tries to do a job. It tries to kill. It secretes this beautiful killing substance called interferon gamma. Unfortunately, prostate tumor cells and many other tumor cells sense that, and they react to the interferon by upregulating the foot on the brake. So next slide, please. That's called PD-L1. So this is the setting that's sort of an unstable setting. You got killer cells in the tumor. They're poised, locked and loaded, as our president says. They're ready to go, right? But they can't go because the PD-L1 is pressing on the PD-1, and that turns them off. If you block that interaction with an antibody or a drug like Keytruda, what happens? Next slide, please. Next slide, please. This is the Keytruda molecules coming in. Next slide, please. Is the T cell comes back to life, it gets reactivated, and if you're lucky, it can kill the tumor cell. Next slide, please. And it goes away, actually. So that's how PD-1 blockade works. But you can see from that picture is that for that to work, you need the cells to be there in the first place. And unfortunately, in prostate cancer, that occurs in a relative minority of the patient. Next slide, please. This is the first trial of anti-PD-1 in prostate cancer. Next slide, please. And unfortunately, this trial has treated about 17 patients with prostate cancer, and by itself, it didn't work. Next slide, please. Next slide, please. This is just a diagram showing on the left. Now we're staining for those killer cells. The brown dots are those killer T cells. This is a normal prostate cancer cell, and you see like almost none of these bright dots that indicate immune cells. It turns out that hormonal therapy is in fact immunotherapy. This is these are data from a paper we just published looking at the prostate gland in men who are treated with hormonal therapy prior to surgery. You can see about twice as many immune cells after hormonal therapy. So hormonal therapy, ADT, is in fact, at least in the beginning, immunotherapy. Next slide, please. There was a small trial that we published actually where we combined hormonal therapy, enzalutamide, with immunotherapy, Keytruda. This is the schema. Men with prostate cancer were treated who were on enzalutamide and were progressing, got treated with Keytruda, also known as MK3475. Next slide, please. And you can see actually that sometimes this worked brilliantly. So each row is a patient. In these patients, sometimes there were brilliant responses. These are 5 of the responders. We had patients with PSAs going from 70 down to 0.8. One patient had a PSA of 2,500, went down to undetectable. Other patients who responded. So it looks like if you add hormonal therapy, and this is second generation hormonal therapy, to immunotherapy, sometimes you can see brilliant responses. This has been published and presented, and now there's a large randomized trial based on this. Next slide, please. So this brings us up to the last point that I want to make, and that's about the idea of what you as an individual can think about doing if you have prostate cancer, especially when you're thinking about switching treatments. So that's the idea of enrolling in a clinical trial. Every drug I just mentioned came to us through the courtesy of volunteers who enrolled in clinical trials, actually. There are 3 phases of clinical trials. It's important to know these when somebody talks to you about a trial. There's phase 1 trials, is the first time you give a drug to humans. The idea for here is just to see if the drug is safe. But I can tell you in the phase 1 trial of anti-PD-1, this was Opdivo, there were patients who had complete responses, actually. So just because it's an early trial doesn't mean it's not going to work, but that's not the purpose of the phase 1 trial. There we're trying to determine safety and trying to pick out a dose. A phase 2 trial is usually a single-arm trial where we think we got the dose right, and then we're trying to see if it works. Does it shrink the tumor? Does it help patients to live a little bit longer? These trials generally involve 40 to 100 patients or so. And we have, at Columbia, for example, we have about 5 phase 2 trials open. The phase 3 trials are the ones that many patients have access to. These are large randomized controlled trials. And it's important to say, a lot of people think that we're comparing to placebo. We're not, actually. Phase 3 trials should never, ever really compare to placebo. It should compare to what you would normally get if you weren't on a trial. So, for example, if you would normally get chemotherapy, the trial to do is not to give chemotherapy versus placebo, right? It's the chemotherapy versus chemotherapy plus something else, actually. So these are the construction of our normal phase 3 trials. Next slide, please. This is what we look at when we look at trials, and these are complicated pictures, but really they're kind of simple. So these are patients who are on abiraterone, they're on Zytiga, and the Zytiga has stopped working. And what this trial did was it randomized patients to go on enzalutamide, Xtandi, which is a pretty good choice. It's a reasonable idea to give patients who are progressing on that abiraterone, on the Zytiga, Xtandi. So this is normally what patients might get. As a matter of fact, they were so eager to get this that this trial enrolled in about 9 months, actually. The other arm got some extra mustard. In addition to the enzalutamide, it got an anti-PD-L1 antibody called atezolizumab. This is what a trial looks like, actually. And so this is what many of you will think about or be used on, actually. Next slide, please. So what are the pros and cons of trial? One idea is it turns out that patients who are on a trial, even if they get the regular therapy, right, even if they get the standard care, they always do better. And the reason is not because the doctors who run trials are smarter, it's because the nurses are really trained to make sure that all your treatment happens on time and all your labs happen and things like that, actually. So that's one possible advantage. The other idea is getting new drugs early on, as I mentioned, early monitoring, and sort of an altruistic benefit for helping future generations. But these trials are not necessarily a walk in the park. Many of them do require more frequent visits. And of course, we're doing this trial, and as a scientist, I like to call it an experiment. This is an experiment, right? So that trial I showed you is an experiment to see if atezolizumab makes enzalutamide work better. And so the hypothesis is, yeah, man, if you get enzalutamide with atezolizumab, it's going to be better. You're going to live longer than if you didn't. We don't know if that's the case, or else we shouldn't be doing an experiment, right? It could also be that in some of these trials, sometimes the treatment makes patients worse. Usually that's not the case in phase 3 trials. Usually we have an idea it's going to work, but still it's something to think about. Next slide, please. So where are you going to get the trial? Who to ask, right? So one thing you should ask is what kind of patients it's looking for. You should really understand the treatment, why it's being tested. You should always know your options. You should always know your side effects. This will be in a long legal document called the informed consent, which is very painful to read. I have to be honest. How often do you have to come in, and how long does a trial last? Next slide, please. So how do you find out about trials? One is you could ask your doctor, but that doesn't always work. And I think Joe will jump in after this and say that many doctors aren't really aware of what trials are ongoing, especially if they do lots of different kinds of cancer. You can use this database, clinicaltrials.gov. It's pretty good, although it's really hard for a layman and even for a doctor sometimes to tell like what's going on, what trials are open and how they're going. Us too, as a prostate cancer advocacy organization, they have a website that's pretty good. It's a little bit more explanatory than clinicaltrials.gov. But the number one source, I think, should always be listed as Joel Nowak, who knows many things about trials and what is going on in the world, actually. Often you'll hear from your friends and words of mouth from support groups too. But it's always important, I think, as you're making a switch in your care. If you're on Lupron and it looks like it's stopping working, rather than just jumping into the next treatment, think to yourself, is there a trial out there for me? Is something I should do? So I think with that, we'll go to the summary at the end. Next slide. So the summary actually is many prostate cancer patients will do well, many for a long time. Hormonal therapy is a blessing and a curse. It works. It basically works, and it often works for a very long time. However, the side effects are something we really need to work to treat, actually. If hormonal therapy stops working, there's a lot of choices. Immunotherapy is not quite there for prostate cancer. There are 2 FDA-approved immunotherapies for prostate cancer, not one. There's sipuleucel-T, and also Keytruda is approved, FDA-approved for patients who have those mutations, actually. As patients progress, it's always important to consider about trials. In terms of this world of COVID, a couple things. Hormonal therapy is probably not a risk factor. It's probably on your side. Chemotherapy probably is a risk factor. Anti-PD-1 treatments like Keytruda activate the cells in your immune system. They're probably good for you. They probably help you to fight the virus. So far in our cancer center and in large databases, we haven't seen any increased risk in those patients. But the number of those patients with prostate cancer who are being treated with Keytruda is small, so we don't know that for sure, actually. The other risk factor, that's something that you can't fix, is age. Patients who are a little bit older are probably more at risk for COVID infection and complications of that. Unfortunately, that's nothing that you can do about it, but it is something to keep in mind. With that, I think we'll have a few minutes for questions. We have the next slide, please, Jen. And I'd like to thank you for your attention, actually.
Great. Thank you so much, Dr. Drake. First, in reference to the genetics that you gave, was a great explanation, but if somebody wants to deep dive into that even more, We did a webinar yesterday with Dr. Ellie Van Allen from the Broad and Dana-Farber, and specifically about genetics and metastatic prostate cancer, and that's up on YouTube, Cancer ABC's YouTube channel. You may want to take a listen to that. There is a question here. There are a few questions, and the question is, has there been any research looking to combine the immune therapy, specifically Provenge, with perhaps Keytruda?
Yeah, there have been small studies actually looking at combining Provenge, not so much with Keytruda, but with an older immunotherapy called ipilimumab or Yervoy. That trial was a small trial, gave the drugs before surgery, and showed an increase in the number of T cells. But there haven't been large, especially registrational or industrial-sized phase 3 trials as of yet. It's a very good idea, and people are thinking about that. There is a trial combining Provenge with the bone-targeted drug called Xofigo. That trial is really promising. Provenge, one of the challenges with it is that it doesn't usually drop your PSA. And so, how do you know it's working is something that patients often ask. It turns out that Xofigo, actually, that there's a radiation, kind of radiation that is given IV and goes right to the bones. Also, doesn't usually drop your PSA, but there's been some interesting data when you combine the two, Xofigo plus Provenge, that you see PSAs dropping. This is a trial by Dr. Oliver Sortar and by Emmanuel Antonarakis. It's being opened at a couple of sites. And that's really fascinating because it shows that like 1 + 1 isn't 2, right? 1 + 1 in some cases is more than 2. So that's where one of the interesting combinations are. But I can tell you that the folks who make Keytruda have now four randomized trials combining Keytruda with different therapies. One with chemotherapy, one with hormonal therapy, one with the PARP inhibitor olaparib that we talked about, and one where the drug is given really early when patients first have metastatic disease. So there's four trials in which patients can get immunotherapy in combination with the standard care therapy. These are phase 3 trials, right? So the comparison is chemotherapy versus chemotherapy plus Keytruda. Your chemotherapy on that trial will be great. People will watch you like a hawk. So it will be good chemotherapy versus that plus Keytruda. That's an example of the trials that are combining immunotherapy that are going on now.
Great. So you touched on a really important point, and I know that a lot of people are a little cynical about hormone therapy, particularly Provenge, because PSA doesn't seem to be affected. Can you talk about that? And since PSA is not affected, you made a clear statement that it does work. How do we know that? Why do you say that?
It's a great question, actually. So the reason that FDA got approved is because it helped patients to live longer. So patients were randomized to best treatment versus best treatment plus Provenge, and then they were followed to see how long they live. And the patients who were treated.
I think we lost you, Dr. Drake.
With the Provenge live statistically significantly longer. So that's how we know it worked. That picture I showed of the ball, the hot tumor cell, it's not really that simple. There's an ongoing battle, right? And so I think that basically what Provenge does is it tips the battle so that the immune system is winning more than it's not winning, actually. But the cancer is still there and it's fighting back. So basically it kind of just tips the balance and resets it. But that's why it doesn't drop the PSA.
Right. Now we lost you on the internet in the middle of your conversation. So you know, basically, I don't want you to repeat the whole thing, but basically PSA in this particular case doesn't mean that it might not be effective. Is that a good summation?
Correct.
Okay, good.
Yes. And because it helps patients to live longer, actually.
Right.
You know, so I got to answer, Matt. So somebody wrote, my friend Len wrote, can Dr. Drake let us know what immuno trials he is recruiting for? And you know, I can't resist that one.
Go for it.
So our group actually believes, and we have data from animal models to support this, that if you're going to activate the immune system, the time to do it is early on. So we have 3 really cool trials, okay? So one trial is for patients who have rising PSA, just rising PSA. And as Joel asked, this is patients whose PSAs are going up quick. For that trial, what we do is we give a short course of hormonal therapy, just 4 months, 4 shots with a drug called Vegarelix with anti-PD-1, Opdivo. So the idea is, can Opdivo plus degarelix lead to a state where some patients' cancer goes away? How are we going to know that? So we're going to stop the treatment, and then the testosterone will recover. And our hope, our real hope, and this works in mice, is that the PSA will not come back. So that's one trial. It's called Magic 8. Our other trial is for patients who come in with metastatic disease, right? And one treatment would be to hit you up front hard with hormonal therapy plus chemotherapy. If you really want to pile on, come to us. We have a trial called Prime Cut, where we give chemotherapy, hormonal therapy, and powerful immunotherapies. This is a drug called cemiplimab from Regeneron. It's very, very similar to Keytruda. So all three treatments right up front, actually. In the later stage, we have treatments that are designed to drag T cells to tumors and make those cold tumors hot. But I think the ones that we think are really exciting are the ones where we give immunotherapy on the early side.
So if I'm interested in participating in any of your trials, how do I reach out to you or to Columbia?
Yeah, that's a great question. So the best way is the best way to really talk, right, is in person. It's hard in this time of COVID, right? But it's best to come in actually and have a new patient visit. I don't have the contact information handy, Joel, but I can give it to you. But the idea is you come in for a new patient visit, we go through your history, we look at the treatments you've had so far, and we talk to you, right? We have to see like what kind of things you're interested in, what kind of time commitment you have, and then we talk about our options. My goal of our program actually has been to have an immunotherapy trial available for most prostate cancer patients, wherever they are in their journey.
So that's good. So if you let me know what the contact method or information is, I'll make sure that we let anybody who's either listening or who listens on YouTube how to reach out to you, because I think you're going to get some responses because your trials are terrific. It's now 4:06. I don't want to hold you up unless you've got time for another question or two, but it's your choice. You let us know.
I got to answer Ramon's questions. He's asked a lot of good questions here. So Ramon,
okay, go ahead.
Actually, can you use Provenge with the new oral meds? Are the results better? So it's great questions, actually. So the answer is yes. Of course, you can use Provenge either before or after it's approved for metastatic castrate-resistant prostate cancer. So it's fine. You can use it. We did trials where we combined Provenge with Xtandi or with abiraterone, and it looked like it worked, if anything, a little bit better, not worse. But Ramon, you should remember, those are not large randomized controlled trials. So the answer, you can use it. It's almost certainly not worse. But your question was good. I mean, very brilliant questions. Are the results better? And really, to understand better, you got to do a pretty big randomized controlled trial. So we don't think it's worse, but I can't convince you, or I shouldn't try to convince you that it's better until we have more data.
Okay. Are there any other questions in the peanut gallery while we still grab hold of the doctor? So the other question I do have, PD-1 inhibitors takes the brakes off the immune system. So someone who has an autoimmune illness or their own immune system is attacking their body, can they consider a PD-1 inhibitor?
That's a wonderful question, actually. So in all the clinical trials of anti-PD-1 inhibitors, patients with autoimmune disease were prohibited from entering, right? And so we don't have a lot of data on whether somebody with arthritis, lupus, colitis can really use those drugs. From my personal experience, particularly in cancers where these drugs work very, very well, like kidney cancer or bladder cancer, we have occasionally taken patients who don't really have a lot of options and treated them with anti-PD-1 drugs. It turns out that if the autoimmune disease is kind of burnt out for a long time ago, like colitis, sometimes we don't see a flare. For example, I have a patient in my clinic right now who has a history of colitis but hasn't had a flare for about 5 years, getting anti-PD-1 for their kidney cancer. It's going just fine, actually. But these drugs are often used in other cancers like melanoma. And Jeff Weber at NYU published a couple of papers on this, and it is a bit of a risk, actually. So patients can have a flare of their disease that could be dangerous. But if they're in a position where their cancer is more dangerous, then the risk versus benefit sometimes is for trying the drugs, right?
Right. So terrific.
Question.
Are you okay, Dr. Drake, with some more questions? Because again, I'm cognizant of the time.
I have a question. Do prostate oncologists like Dr. Hussein know much about what you're talking about? so that they would then know to perhaps direct someone to you or another person in getting into trials?
That's a wonderful question, actually. Doctors like my friend Maha Hussein and many other ones are very familiar with the standard treatments for prostate cancer, chemotherapy, hormonal therapy, and things like that, actually. But they don't often or always have as much experience with the immunotherapies, actually. And so when we were using these drugs, actually, it was really limited to doctors who took care of kidney, bladder, melanoma cancers. But what's happening now is these drugs are so widely used that more and more oncologists are getting experience, actually. And so they're getting more experience with both the trials and how to manage the side effects. I can tell you honestly, managing the side effects of these drugs is not exactly like rocket science medicine. The idea is when you see bad side effects, you can give immunosuppressive medicines. But the important part is not that. The important part is the recognition, right? So if you recognize those kind of side effects early on and treat, you can do a great job putting out the fire. If you wait too long, it becomes much, 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 much harder. So it's not really so much the expertise in treating the side effects, it's kind of knowing when to do that. And I think it's becoming more prevalent through oncology and also awareness of the immunotherapy trials. So I think it's, I think my last slide said a work in progress. I think true. I think that's a good way to put it.
Thank you very much.
Good.
Oh,
So
pleasure.
I'm actually in respect to Dr. Drake's time, because I know he's got 4 minutes and he's on somewhere else. Thank you very much. If anybody has any additional questions, and I noticed there are a couple on our chat thing that we haven't gotten to, if you send it to Jan or you send it to me, we will send a notice out, or we'll reach out to Dr. Drake on your behalf and forward his response to you. I really want to thank you so much from the bottom of my heart for your coming on today. I know you're really busy. I think this was a fantastic opportunity for everyone. So thank you, sir.
My pleasure. Great to see you, Joel.
Okay.
Thank you, Dr.
Take care, everybody.
I appreciate it.
Okay.
Thanks.
Bye. Thank you.
Thanks, Jan. Thanks for turning the slides.
Yeah, it was a little slow, but we did it. Thank you.
Thanks.